Welcome to Cancer Newsline, a podcast series from the University of Texas MD Anderson Cancer Center. Cancer Newsline helps you stay current with the news on cancer research, diagnosis, treatment, and prevention, providing the latest information on reducing your family's cancer risk. I'm your host, Lisa Garvin. Today, we're talking with Dr. Joe Chang, who is an associate professor of radiation oncology here at MD Anderson and also director of the Stereotactic radiation program. Our subject today is stereotactic body radiation, also known as SBRT. Let's start with the elementary, Dr. Chang. What is SBRT?
The unique part of SBRT is to deliver very high biological dose to the tumor, in the meantime minimize the dose exposure to the surrounding critical structure. Compared with conventional radiation therapy, which require 7 weeks radiation therapy and about 70 grams of dose of biological dose, stereotactic radiation therapy deliver double the dose within 1 week.
Now, this is not really a new procedure, but there have been a lot of developments recently, has there not?
Right, because recently we have what we call imaging-guided radiation therapy, and also four-dimensional CT imaging-guided treatment planning. We take the motion into consideration. We can deliver those more precisely to the target, for example, the lung cancer, more precisely, and then we can afford to have a tight margin because of verification by CT on board.
Now, people who are maybe not familiar or have not undergone radiation therapy, it's very important that they stay still and that they're always in the same position. So when you're talking about movement, we're talking about movement of organs and the tumor itself, correct?
Right.
So in typical radiation therapy, there's a frame that's built to hold them in the same position. But the CT on rails, as you described, negates the need for such a frame.
Right, because for either combing CT or CT on rail, we do it before each procedure. So every single day, we verify we're targeting exact right spot. We only allow less than 2 to 3 millimeter uncertainty with the CT on rail or combing CT.
Now, what sorts of cancers are you starting to treat with SBRT?
Most of the time, it's the lung cancer, early-stage lung cancer who is not a good candidate for surgical resection because of other medical problems, such as diabetes, cardiovascular disease, or poor lung function. Another group of patient is a patient who have a history of lung cancer, has been treated surgically or with definitive radiation therapy, but recur in other part of the lung. And that group of people either recur from prior cancer or secondary lung cancer, they can be treated with stereotactic radiation therapy. The third group is patients who have a different type of cancer, but the cancer spread from primary, either colon, rectal, or pancreatic cancer, sarcoma, or melanoma. They spread to the lung or liver or adrenal. We can treat with stereotactic radiation therapy or SBRT using this technique.
So basically, cancers that are in the thoracic region, it sounds like.
Thoracic or liver or even adrenal.
Now, is this something that's available at all cancer centers, or is this something that's only at maybe some of the bigger centers like MD Anderson? Is this a standard treatment?
Currently, for early-stage lung cancer who is not a good candidate for surgical resection, that has been a standard. However, in MD Anderson Cancer Center, we have most experience. We treat about 1,000 patients with this technique. We gained so much experience, and we published several papers that treat the challenging cases for lung cancer. So, and also, we have a proton available here. If patient need a proton treatment, also use a stereotactic proton treatment, also available in our institution. So, we do have a lot of experience, and also we have all the cutting-edge technology.
So, and I think that that's a distinction that people can't always make about radiation therapy. There are several different types. And so the stereotactic part is the intraoperative imaging, where you're imaging the tumor site as you are doing the radiation therapy. Right. So you can actually use other types of radiation therapy in the stereotactic setting.
Exactly.
Okay.
You can use a proton photon, IMRT, 3D conformal, different type technology, but use the concept of stereotactic, which is mean deliver ablative dose to the target and avoiding surrounding critical structure.
And I know in the radiation therapy world, there's been a lot of work in trying to reduce the number of treatment sessions by introducing a higher dose. Is that kind of where we're moving?
Right, exactly. I mean, you can imagine for conventional radiation therapy, typically for lung cancer, you need 7 weeks of radiation therapy, that daily treatment for 35 fraction. Nowadays, for early stage lung cancer using the SBRT, we finish in 4 days. 4 days compared with 7 weeks, 35 fraction. But biological dose doubled almost.
And I know there are obviously concerns about higher doses. And what have you seen as far as the effectiveness of fewer treatments and higher doses? Do you have data to kind of bear out that it's a good thing?
Sure. Our center and also other center published several data. In our hands, the local control, which means the tumor recur in the spot we treated, is 98%, which means only 2% of patients recur locally in the area we treated. The data is comparable with surgical resection. That's the unique part about it, because we deliver ablative dose to the target. So no matter what kind of histology, if by that kind of dose, it can eliminate the cancer totally.
And what sort of research are you doing on SBRT? Are you hoping to focus on other tumor sites or other types of cancers? What sort of things are you looking at in the future?
A few research projects is going on in our center, including treat patients with operable early-stage lung cancer. As we all know, standard treatment for operable stage 1 lung cancer is a surgical resection that need to remove one lobe of lung, do the mediastinal lymph node dissection. So now the question is whether stereotactic can be comparable for surgical resection in operable patients. So we're doing phase 2, and also phase 3 randomized study, which means give 50-50% chance to each group and randomize the patient to either surgical resection or SBRT. So we'll see whether they are comparable or not. That's one of major research direction. The second is we are doing patient for challenging case, such as case tumor very close to the critical structure, or patient has been treated with prior radiation therapy, which means they are tolerated radiation poorly, or patient who have other type of cancer and spread to lung, liver, or adrenal with multiple mets. So all those cases previously is only treated with palliative chemotherapy, but now we aim for potential cure. That's our research project we are doing, and that's the result looks like promising.
And is SBRT used as a frontline treatment in these cases, or is it adjuvant therapy with surgery and or chemo? It sounds like it's a frontline treatment in many cases.
Well, it depends on if it's medically inoperable early stage lung cancer, then SBRT is frontline treatment for sure. For patients with recurrent or metastatic cancer spread to the lung, then systematic treatment, including chemotherapy, biological treatment, will be the mainstream treatment. But radiation therapy using stereotactic function as the boost to the local area. So it can combine with other type of treatment together in many disease situations.
And what about the patients you've used SBRT on? What sort of reaction or feedback have you gotten from them?
Well, most of the patients I saw after 5 years of lung cancer are patients who treat with stereotactic radiation therapy.
You mean reaching the 5-year survival mark?
Mm-hmm. Right, because it's definitive treatment, we aim for cure for early stage lung cancer. And the patients love the procedure. First of all, it's non-invasive. Second, it finishes in 1 week and minimal side effect. Some patients even joke, say, well, are you sure the machine, you turn on the machine? Because I don't feel anything. So patients love it, particularly for people who is more senior, who may not like the idea to open up the chest. So we get a very good feedback from our patient.
Let's talk about the typical effects of standard radiation therapy. What are the typical side effects of radiation therapy in general?
In general, radiation therapy is energy, so it goes through the skin to hit the target. So patients typically have skin reaction. Most most of the time, it's just like sunburn. It's tolerable, minimal, or occasionally moderate. And second side effect is, as you can imagine, if we're treating lung cancer, we're going to burn that part of the lung with radiation. So that part lung may become scarred down in the row. So if patients have a very poor lung function, then additional lung damage could cause worsening short spurts. But it typically only happens in about 10% of the time. About 3% of the time could be chronic and severe. Those two are common side effects. Another side effect is chest wall pain. If tumor is close to the chest wall, as you can imagine, it can irritate the chest wall rib nerve by radiation therapy. So patient may have a pain in the chest wall. That happens about 10 to 15% of time. Again, most of the time is mild to moderate. Those three are most common side effects from radiation therapy, including stereotactic radiation therapy. Of course, we need to respect the dose exposure to esophagus, spinal cord, bronchial plexus, heart. Those critical structures we need to pay attention to. That's the reason that if you do the stereotactic radiation therapy, it's better to go to the main center who have more experience, who know all the tolerance dose, and who treat with this technique all the time.
So should patients that are possibly eligible, should they be asking about SBRT? Is that something they can ask their oncologist about?
Sure. If they have early stage lung cancer, if they have a recurrent lung cancer recur in the lung parenchyma, or if they had a metastatic disease to the lung or liver, adrenal, they should ask the physician, say, well, whether SBRT is another option, and then get a consult from radiation oncologist, and we can give you assessment to see whether you are a good candidate for SBRT.
Your typical patient for SBRT is early-stage lung cancer, and now typically lung cancer is not caught at the early stage, but things are changing in that respect, aren't they?
Right. I mean, as you know, the NCI support research project for lung screening program found that with spiral CT screening in high-risk patients, screening actively can reduce lung cancer-related deaths 20%. To reduce the 20%. So currently, one unique part about our program is we can integrate to part of a management for patients who underwent the lung screening program and found to have lung cancer, and then they can do either surgical resection if they can tolerate, or they can do SBRT.
So who are considered the high-risk groups that would be eligible for lung cancer screening?
Typically, a patient who is chronic smoker, smoke more than 30 years, or 50 or 55-year-old patient who is high risk for lung cancer.
Great. Thank you very much, Dr. Chang.
My pleasure. Thank you.
If you have questions about anything you've heard today on Cancer Newsline, contact Ask MD Anderson at 1-877-MDA-6789 or online at www.mdanderson.org/ask. Thank you for listening to this episode of Cancer Newsline. Tune in for the next podcast in our series.